in some of the drugs. So we know that iron overload is the most common cause of problems in people who have hemoglobinopathies. And iron overload is a combination of the iron from transfusions that people have, and that's the most common cause. But in fact, we know a lot now about iron, and we know that people who have abnormal or different hemoglobins, we like to sort of talk about them as more different hemoglobins, that they don't process iron as a person who has a standard hemoglobin A does, and their gut absorbs more iron, regardless of the fact that they're having transfusions or not. And so we see patients or people who have the thalassemias or the sickle cell disorders actually can have a predisposition to having iron overload, whether they actually are having transfusions or not. And then, of course, this is compounded, particularly with people who are having regular transfusions. And that's the biggest burden. We know that from the point of time where people have approximately 20 transfusions over their lifetime, they start to run into problems with too much iron. And so for people who are having transfusions 2 or 3 bags every 2 or 3 weeks, you get up to 20 very quickly. And obviously it's a big issue. So iron is just the chemical element iron. It's the 4th most common element in the Earth's crust, so it's quite important. And it's really important in the body because not only is it important for hemoglobin, but it's actually one of the key components in a lot of enzymes around the body, as well as in DNA synthesis and growth. So it's actually really important. One of the very common problems is people who are low in iron, and it's really important that we keep people in a nice middle range of iron. We don't want people too low or too high because it causes lots of problems either way. Iron's absorbed from our gut, and so every time we eat food, we're absorbing iron from the duodenum, the second part of the gut there. And when iron's absorbed from the gut, we absorb 1 or 2 milligrams a day. And with that, it deposits in the liver, which is where it's stored. It gets used in the bone marrow and the red cells, and then also in this system called the reticular endothelial system. That's the garbage can of the blood, really. So the reticular endothelial system is some cells in the blood as well as in the spleen that mop up all of the garbage in the blood, and they also need iron to operate, and they take up quite a bit of iron and store quite a bit of iron. But as you can sort of see, this is a really active system. So iron's moving around all the time around our bodies, essentially transported by a protein called ferritin, transferrin, and ferritin reflects the stores of iron. And so the iron tests, when we do a set of iron tests, we're looking at a number of different levels that give us an idea about the level of iron in the storage as well as the level of iron in the blood. And that sort of reflects the iron moving around. So each bag of blood, each single bag of blood contains 100 to 200 times more iron than an average person needs in their daily uptake. So that's a lot of iron. And if you're imagining if you're getting 1 or 2 bags of blood, often people with thalassemia major, for example, are getting 2 bags of blood every 2 weeks or 2 or 3 every 3 weeks. You can imagine how much more that is. And so it's very easy to see how iron overload becomes a big problem. The iron in these blood cells is just treated just like blood cells in our normal body. The blood cells break down, and the iron that's contained within these blood cells is broken down, and it's transported mostly to the liver, but also to the heart, where it can be stored. And the liver's the number one spot, but when the liver's full or has too much iron, the heart becomes essentially a storage place for iron as well. And it accumulates in the bodies of people who are receiving iron, to have too much iron, receiving regular transfusions.
So chelation therapy is a good idea?
Generally a good idea, yeah. We'll get to why that's important. Yeah, absolutely. So the problem is our bodies don't get rid of iron very well. So we do, in someone who has normal iron absorption, when they eat, the iron they take in, they absorb that 1 or 2 milligrams a day, and the rest goes out to the keeper, down the bathroom. Whereas when you're giving iron already directly into the blood, your body's got no opportunity to get rid of that iron. It's already depositing in the elements of your blood, not only in the blood but the liver and the heart. And that's why we need things like chelation therapy, because the body just has no mechanism of getting rid of this. This is not a normal thing for the body. So what happens when we've got too much iron? And so there's a protein. This is sort of a bit of fancy work that, so Dr. Santa Pravisha is Santnarayan Pravisha. He's a doctor at Royal Melbourne. He works very closely with us. He's basically my 2IC on the clinical side. But he's the lead, and he's employed also by WHO, so the World Health Organisation, looking very much into iron metabolism. in patients who are either low in iron or too much iron, and we're doing a number of studies looking at the mechanism by which iron moves around the body and by which the body is told where to place that iron, the heart or the liver, and how it works, see if we can work around that. He's doing work at the Walter and Eliza Hall, which is part of our institute. And so this protein called hepcidin, which he's doing a lot of work on, it inhibits the take-up of iron from the intestine. So if you've got lots of hepcidin, you reduce the amount of iron you're absorbing. But in people with beta thalassemia, we've recognised now that that level's actually very, very low. And so that's why they absorb too much iron from the intestine. And we don't know why that is, but it's a byproduct of the thalassemia, and the gene mutation that causes thalassemia also causes this abnormality with the iron. And so we're also looking at the moment, we don't know in people with sickle cell diseases or sickle beta thalassemia diseases whether that's the same. And so currently we're doing a study in people with sickle cell diseases to have a look and see if that's actually the same for them as well. And so in someone who has too much iron, if they're not on chelation therapy, that iron will be deposited, as I said, the heart, the liver, but it can also be deposited in a lot of the other organs, the pituitary gland, some of the other endocrine glands, the thyroid and hormones can be affected. And that's sort of an example of a liver scan. So many, you may be familiar with the Ferry scans, the MRI scans, to look at the iron levels in the liver, which have been around for the last sort of 7-8 years, I think, since they developed the software. And essentially it's a normal MRI scan, but what's special about it is the software that goes with it that enables the scanner to look at the amount of iron. And that'll get sent to Perth. The data of people in Perth actually developed the program for the Ferry scan. And they analyse that and give us a sort of a graph here on the side where you can see normal iron should be down here, and this is someone who's got too much iron, and that's sort of the brightness of the picture there we can see as well, which tells us how much iron. That's quite useful because our blood tests don't always give us a really good idea how much is in the liver and how much is in the heart, and the MRI scan of the heart shows us that as well. So what is the effect? Unfortunately, the effect of too much iron is basically the heart and liver don't work properly. And so the worst case scenario is failure of the heart. So the heart muscles don't pump properly, can lead to shortness of breath, swelling of the legs, and worst case scenario, people can die of heart failure and liver failure, which can cause scarring of the liver, but also gives people a higher risk of getting a cancer of the liver called hepatocellular carcinoma, and that's something we would worry about, obviously, quite a lot. But the good news is if treated early, all of these effects are very reversible, and that's where iron chelation comes in. And what's also important is that people who have too much liver iron don't always have too much heart iron, and the reverse is true. So it's not always you've got lots of iron, it's everywhere. You can have some in the liver, lots in the liver, but none in the heart, or vice versa. So it's really important we check both spots every time to make sure that we're not missing something that we can treat. Yes, madam.
What happens when a person, say, does have a little bit of storage in their vital organs? You said that it was reversible. Mm-hmm. How reversible is it? And what are these tests for? What are you testing for? I mean, it might sound like a stupid question, but what are you going to do about it anyway?
Yeah, so what we're testing for, first of all, to see is where the iron is. So we're doing a blood test to look at how much iron there is in the bloodstream, and that gives us also an idea of how much iron is stored in the body. But then the scans, the MRI scans of the heart and the liver, give us a really good picture of how much iron is deposited in the heart and the liver.
That wasn't my
and then
question.
We look at
the question was, so just say you do find a little bit of iron there.
Yep.
What's the cure for that?
Yep.
Operation?
So chelation therapy.
Oh.
Chelation therapy. So the other test we want to do if we find too much iron there is we want to do tests to make sure the heart and liver are working properly. So an ultrasound of the heart called an echo to make sure the heart's pumping properly.
Don't you think the patient would realise that themselves by how they feel?
No, not always. So often people can have heart function that's down to about 20% of normal before they start to feel unwell if they're otherwise young and fit. And so often it can get to quite a severe level of problems before someone can feel unwell or have problems such as swelling of their ankles or shortness of breath, for example, with the heart. And with the liver,
but
the liver
swelling
can
of
be
the
quite sick.
ankle is also, when a woman's pregnant, her ankles swell.
Absolutely. There's lots of reasons why people have swelling of the ankles. Yeah, and this is only one of them. Yeah. So we need to look at the big picture and the whole picture. Absolutely. So I've already talked about the monitoring of the iron there. So really the goal of chelation therapy is about removing the excess iron. But the big goal, what we should really aim for, is preventing excess iron from developing in the first place. So ideally, what we'd be doing is from an early age, as soon as we recognise that there's a risk of iron overload, is from starting people on chelation therapy to optimise or to improve their iron and to prevent them from getting iron overload in the first place, to prevent damage in the first place. However, we all know that it's not an ideal world, and for lots and lots of different reasons people do get iron overload, and sometimes that's because they've not been managed in Australia, where they've had access to all of our good drug system where we can access these drugs before. Sometimes people have gone through tough times, and sometimes people have decided for various reasons that taking iron chelation wasn't for them at various stages. And so for lots of different reasons we see people with too much iron, and we work to reduce it.
Can I say something, Doctor? As a thalassemia patient myself, I'm a beta major thalassemia. I was on Desperol and then DBL for at least 25, 30 years. I know about 20 years actually. And it was like torture. I still had scar tissue all over my body. You know, I'll give them up the retina to show you all the spots. Kidding, but like, it's very difficult.
It was very difficult.
And then when X-ray came along, it was ulcers.
Yes.
You know, so it's not a choice that we're making because we're being fussy.
Oh, no, and I'm not implying that at all.
Torture.
It's very, very difficult to keep up with iron chelation therapy, and we totally recognise that. And it's not a judgment. It's not a judgment to say people are bad because they're not taking it. It's just say that through lots of different reasons, people are not taking their therapy, whether at that stage of their life it doesn't work out because complications are too great, or whether in fact, for various reasons people have made decisions not to do it. There's lots of, we've treated lots of patients in this situation, seen all sorts of reasons why people aren't taking their iron therapy from, it's just too hard, or they've made a decision right now that, they don't want to do that at the moment, and that's all okay.
I mean, I took my blood transfusions because I was worried about the iron overload. You know? Anyway, I went back home.
Okay.
I'm fine now.
So iron chelators are drugs that bind and remove iron from the body. So they were actually first discovered around World War II, which is really interesting. So they were looking for a cure for arsenic poisoning. And a chelator is a term for a drug or a substance that binds to a heavy metal. And iron in the end is a heavy metal. And so they actually originally discovered these iron chelators when they were searching around for a cure, because arsenic was being used by Germans and other evil forces at the time. It was thought as a poison, and so they were actually looking for antidotes for these poisons. And in the process, they found the molecules that have gone on to become what we know now as the iron chelators. So interesting sort of bit of history. And there are 3 drugs currently available in Australia. So now I always like to call them by their trade names because they're easier to pronounce. The desferoxamine, desferriprone, and desferriox.
And I tried desferriprone as well, and it was toxic.
So they've all got lots of side effects. I think as Belinda's pointed out nicely, they certainly are very difficult to take for a lot of people. So desferrol, we know is administered either subcutaneously or intravenously. And it basically works to bind to the iron and excretes the iron in the urine. And it's important, as again we've noted already, to rotate the sites because you get build up of scar tissue, and that's a really difficult thing. It does have a number of side effects that are very important to monitor and keep a check on. And hearing loss and visual problems or eye problems are a common theme through all the chelating agents, and it's really important to have the hearing and the vision checked for anyone who's on chelation agents. And there's also risks of allergic reactions with it, but it has basically been the mainstay or the backbone of iron chelation therapy now for a long time. Ferroprox was the first oral iron chelator, so via tablet, and it's 3 times a day. It's much smaller, so it's actually more effective at removing iron, but it's also quite difficult to tolerate for a lot of people. And 3 times a day can be difficult to take for a long period of time. Again, a reasonable number of side effects that can cause people to not want to take it as well. And then XJ. So when XJ came on the market, it certainly made a big difference to a lot of people, but by far and away from being perfect. And a few nods in the audience. So, whilst it's the latest and it was touted as the greatest when it came out, it certainly has made a big difference to a lot of people. It combines the iron and excretes it in the faeces, so unlike going to the urine, it actually takes it down through the gut. It has a lot of gastrointestinal side effects, and that's the main reason people hate it and find it really difficult. And it's a nuisance. You know, the granules are difficult. You've got to wait. It's not easy to take in many ways, and there is an increased risk of bleeding from the gut in people who are taking it. And there's also problems with people who have kidney and liver damage. So if people already have kidney or liver trouble, we can't use XJ. But on the other hand, it has made a huge difference to a lot of people.
So we have to drink plenty of milk and water.
Have to drink plenty. So this is the big change. So Jadanu's come in. So Jadanu is desferriox. So it's basically XJ. It's the same drug as XJ. So exactly the same molecule, but it's actually a tablet. It comes in tablets or sprinkles. So the sprinkles are designed for the younger people in the thalassemia sickle cell population. So you can sprinkle them on. It's a really cute ad in the United States. They sprinkle them on applesauce, because applesauce is apparently what you see. The applesauce stuff is what you feed your kids in the US. So sweets of applesauce. So you sprinkle the granules on applesauce. But you could imagine putting it in some jam or sprinkling it. They say sprinkle it in your in a juice or something like that is what they suggest. So it does provide options for patients, and there's no reason why adults can't have the sprinkles either if they prefer sprinkles to a tablet, if they prefer to take it that way. So it does give you a couple of options. It's to be taken either on an empty stomach or with a light meal. So they do say not a full meal, but sort of a light meal, some crackers or some biscuits or something, sort of just an afternoon tea or morning tea type meal is what they suggest.
What about sweet biscuits?
I suspect sweet biscuits are fine from what I've seen. And the dose is actually adjusted to the patient's weight. So the idea is that you start off with a dose according to the person's weight, and then you adjust the dose according to how well the iron's coming off, for example. Now, unfortunately, Novartis has not let us have any in Australia before it's been released. So it's been released in early 2019, and unfortunately no one in Australia has any experience with it, which we're quite disappointed with, because we would have liked to have had a trial with it in a select group of patients. But all of the reports, all of the clinical trials which have been done in the US and Europe have shown much better tolerability, so much less side effects than XJ. Being a tablet, it makes it much easier. Tablet once a day. It's a very attractive option. In fact, it's not going to be an option because so what's actually happening is Jadanu at the moment has been approved by the Pharmaceutical Benefits Advisory Committee, so it's been approved. They're just negotiating on cost at the moment with the government. It will come out in early 2019. Within 3 months of it coming out, XJ will be off the market. So they're taking XJ off the market. So everybody who is currently on XJ will be transferred over to Jadanu within 3 months. So you can get 6-month scripts for XJ. So what will happen is, depending on when you are in that cycle of picking up your next script, most likely your first time when Jadanu is available, you'll be getting a script for Jadanu and XJ, because XJ will no longer be available.
But is it the same side effects such as GI bleeding and
No.
calcium in the urine and protein?
Some of them are and some of them aren't. So
What could be some are?
So the GI, so some of the effects are the same, and this is from the clinical trials. So the GI bleeding looks less than with XJ, and the GIT symptoms, so the nausea, the diarrhea, the feeling sick. Some people are constipated, we've found as well. So all of those really yucky gut symptoms people have, they don't get, but a lot of the others are some of the things like the calcium are the same, because in the end it's the same drug as XJ. It's just packaged in a different way. So the calcium effect is the same, for
So
example,
it's
and the
still
kidney
have-
trouble is still the same.
It's still the same as leaking calcium.
Leaking calcium
And protein.
is still thought to be so it's exactly the same drug, so it doesn't stop those sort of effects. It stops the effects that are from the actual way it's delivered in the gut. So it's not, again, it's not perfect, but it's thought to be a big improvement on XJ. Unfortunately, for whatever reason, the company's not giving anyone any choice. They've decided to take XJ off the market, but we're forewarned. They've given us information about how to change people over. The dose is not the same. It's about 30% less with Jadanu than it is with XJ as well.
Have you had any positive feedback from any of the patients with the XJ?
Yes. Yes, we have some patients who tolerate XJ very well. We also have some patients who find XJ intolerable and don't take it anymore. They take other forms of iron creation. Very much so. And everyone's different for lots of different reasons. So. So the dose is around 30% lower than XJ, but we've actually found, what we're speaking to some of our colleagues in the US and the UK, we've actually found that because XJ is not well tolerated, people are actually often taking a dose lower than what we would ideally give if there were no side effects in the gut. So overall, what they've found, and this is from the colleagues we've been speaking to in the US, is they've found they're actually finding patients eventually are on a higher and better dose of Jadnu than they were of the XJ because they can tolerate it better. So it's allowing people to get a better low iron chelation treatment because they don't get the side effects with the gut, which is usually the thing that stops people having the full dose of their iron chelation therapy, if that makes sense. So it's going to be very much a bit of a trial to see how each individual will discuss with their own haematologist when they're starting about what dose is right for them. And the plan is to start at the per weight dose and move from there up and down as needed.
What's
So
it for pregnant women?
they haven't got all of the data. They haven't got all of the data in pregnant women yet. So the side effects that we've already talked about, still is some ulceration of the stomach and bleeding, but it's not as high as with XJ. The low blood counts, the problem with XJ as well, is still the same problem with kidney, liver trouble. Their kidney and liver troubles are much more problematic in people who are more elderly. And that's the same with XJ as well. And the visual and hearing problems are still a problem as well. One of the things that we're very interested in, so we've got a number of patients who are on either double or triple chelation therapy, so they're taking 2 or 3 of the chelation agents at the one time to try and get their iron levels down. And this is sort of a graph of one of our patients who had a ferritin of 25,000, not ideal, by any means. And so to try and reduce that, we've had this patient on the three different iron chelating agents altogether in a regimen sort of pattern where we've got that organised, and that's been working very well. And that's based on some work out of the UK where they've done a lot of work with 3 chelating agents together. There's no information at the moment about using Jadnu in combination with the other agents, and so we're going to have to start. The advice from Novartis is very much that we should not combine it initially, and so that's going to be somewhat tricky for these small but difficult iron problems that we've got in some patients. We're just going to have to work with that as we go. But it creates a bit of a challenge. But we're going to be we've got a phase 4, which is a post-market study, so when they come onto the drugs come to the market, there are clinical trials called phase 4, which collects all of the data, and so we're running a study at Royal Melbourne Paediatric area around that, collecting data for the Australian use of Jadnu, around how that works, and doing blood levels and checking the blood levels of the drugs and of the iron and collating those as well to get that information locally from patients as well. So the iron chelation works very well when it's taken, but it only works when people do take it. And we've already talked about there's lots of reasons why people are not taking their iron therapy, and Jadnu hopefully will change that for some people. It works best to prevent the build-up of iron, but again, it works very well to reduce the burden of iron in people who already have iron overload. I think the really important point is that we're going to have 3 months from the time Jadnu comes on the market, which will be, no doubt, will be heavily advertised. We have 3 months to transition everybody to Jadnu from XJ before XJ comes off and out of the chemists, out of the pharmacies. So that's going to be really important to work with your haematologist and treating doctors to work around that and how we best move over to Jadnu. We always consider double and triple therapy. It works very, very well in some people in difficult situations, and it's really important also for anyone on iron chelation to have regular monitoring of the side effects. And I did have a couple of slides about our service, but I've talked about that really already. So I think the only thing to mention is apologies tonight from both Rebecca Dring and Claire Dowsing. So Rebecca's our nurse coordinator for thalassemia patients, and Claire is our nurse coordinator for our sickle cell disorders. Rebecca and Claire are currently in London at the Sickle Cell and Thalassemia meeting, and they're touring about 4 different hospitals in London and up into north in the UK. So they've actually got a 2-week tour of hospitals looking at thalassemia and sickle cell services in the UK. And they were at a clinic yesterday. Rebecca texted me where they had 1,200 thalassemia patients coming through the doors. So when you think about our population in Australia, where we've got 60 sickle cell patients and sort of 20 thalassemia patients at the Melbourne, we're not, we can't compete on many levels there. On the other hand, we can really offer in Australia a much more boutique service because we're not dealing with that throughput of those massive numbers. So it allows us to know everybody personally, which is much nicer. And that's our goals of service. So thank you. And any other questions?
I didn't quite understand about the exchange coming off. Like whose decision?
Yeah, it's a drug company's decision.
Okay.
Yeah.
And
So we're
is that
going to
because
control.
is that because they think that the other one, the newly introduced one, do they think that doesn't have as many?
So they own both drugs. So they own both drugs and market both drugs. And I suspect it's got as much to do with how they've got it funded through the government, that it's probably an agreement with the government. So I'm actually on the PBAC committee, which is the committee that funds which decides which drugs go on and off the PBS, which is the government funded scheme. And a lot of the time, companies have to negotiate very hard to get the drugs because, of course, the company wants lots of money for their drug because they've put a lot of money and time and effort into making it. The government wants to pay not much for the drug because they've got lots of people who want it. So there's always this tussle between what the companies want and a lot of negotiation. And one of the reasons they will have done this is essentially it's got to do with what's called patents. So when a drug's been around for a while, it comes what we call off patent, so anyone can make it. And by changing everybody and getting it off the market as well, when it's an old drug, they've ensured that they've got everybody. So it's a marketing thing. They've got everybody who was on Xjade now has to go on Jadneb. And so they've captured the market. So that's my cynical hat on. That's putting my, in some ways a realistic hat on. But to be honest, you guys deserve to know how it works. I think that's got as much to do with it as anything. I think it is a better drug. I mean, it's the same drug in a better package. So it's not worse. We don't know now, that the data suggests it's better tolerated. Now we obviously need to see if that's going to be the case in our population. No reason to think it won't be.
How's things going with the stem cell research?
Mm-hmm. Yeah, so really interesting. So the stem cell research, so for people who are not as familiar with the stem cell research, it's about taking cells from people with a blood disorder, so sickle or thalassemia, for example, taking the blood cells out, using a special virus that manipulates and puts a new genetic sort of code in that replaces the gene that says to make an abnormal haemoglobin with a normal haemoglobin, and then putting those cells back into the patient in a little mini sort of transplant type procedure, usually with a bit of chemotherapy to reduce the immune system for a short while so it's all accepted. So that work's been going on in Europe and the US, and it's been getting more and more successful. It was initially it was a bit tentative, but now there's some really exciting stories coming out of it.
in Australia?
So it's not been. So it hasn't come to Australia, but we're very well positioned. We're currently in talks with 3 different companies around in our centre around this. We're set up to do it. We're already doing this therapy in a disease called Fabry's disease, which is what we call a liposomal storage disorder. So that's a genetic disorder where people have too much of a particular protein that mainly causes problems in the kidneys and things. So we're already using this therapy in Fabry's disease, and we've got a trial in Gaucher disease, which is another what we call a storage disorder where people have a genetic abnormality. So the genetics, it's a different disease, but the concepts are very similar and it's the same sort of treatment. That's already running. And we've got all the facilities to run it locally in Melbourne and to do it all in Melbourne. So as soon as that gene therapy comes that next step and comes to Australia, we'll be in the best position to do it. But experimental therapies don't come to Australia until they're much more established because we just don't have the numbers of people. It's not about how good our science is. We've got science and work that's
but
up.
Is it funding? Is that what's holding you guys back? Or I should say us in Australia?
Funding?
Yeah.
Partially, but it's as much as anything, it's the numbers of patients. So
Australia is going to be organising a walk for thalassemia, and hopefully we can raise lots of funds.
Yeah, we're talking hundreds of millions to run programs like this though, so this is the problem. And we need drug, and it's funded by drug companies.
Hundreds of millions.
Yeah. And it's funded by drug companies, and drug companies aren't going to bring aren't going to invest their big money in Australia until they've got it established overseas with a bigger number of patients, unfortunately.
Is the JP will be the same year, you take it the same day, same time, every single day?
Same day, similar time, every single day. Yep.
You can't miss it.
Well, you can miss it, but ideally,
I find exchange is quite hard to take for my son.
Yeah.
He just found that when we go for party, night out, and then
Yeah.
one is at home,
Yeah.
and then he didn't take it for that day, and it's very hard.
And it
Yeah.
is more.
unlike XJAD, so we know with XJAD that if you skip dose or miss doses, often the side effects are worse when you start it up again. That's what a lot of our patients have found. Whereas Jadnu, because it doesn't have that gut yuckiness, we're hoping, but we don't know, that won't be quite the case. If you miss 1 or 2 doses, it won't be quite as bad when you restart back, but we just don't know until we
To me,
do
it would
it.
be better. Exchange, if my son missed 1 or 2 days without exchange, you should be okay.
Should hopefully be better, but ideally, you know, what the company and what's recommended is taking it at a similar time each day, 1 tablet every day, or 1 or however many tablets. I think the next.
I was wondering if there was a simple reason why you can't chelate blood while you're having a transfusion.
Yep. Should
Should
ask Neil to answer that question. So the problem is that the iron is contained within the haemoglobin, and haemoglobin is the essential molecule that we have in blood that carries oxygen around. And so without iron, haemoglobin isn't a thing, it doesn't exist. And so why you need a transfusion is for that. The problem is it's a catch-22. You need the transfusion for the haemoglobin, but it's the very haemoglobin that has the iron in it. If you stripped the iron out of the, because theoretically you could do that, you know, scientifically it would be theoretically possible, I'm sure, in some way. But if you stripped the iron out of the blood would be nothing more than water. Well, red water, maybe. It wouldn't be effective, it wouldn't be what we call blood, it wouldn't have the goodness that we need in it. So unfortunately you need the iron, and that's the catch-22, you actually need the iron, but only for that short time. What you don't need is when the blood breaks down, that iron has nowhere to go, and that's the problem.
That the Mediterranean diet is excellent.
Good, oh that's good. I think you had a question.
Yeah, I do have a question about Desferol
Yeah.
and the way it's delivered and the drug itself
Yeah.
versus this XJAD or
Jadnu, yeah. So Desferol, we're talking about
Yeah.
the subcut intravenous.
So
Yeah.
you mentioned before about deposits of iron in the heart and the liver.
Mm.
What would be your opinion on the effectiveness of a Desferol and the way it's delivered versus this new drug?
I think the most important thing with any chelation therapy is that someone's able to take it. And so they only work if you're able to actually take it. So if the Jadnu turns out to be better for any one individual, then it's better than Desferol if Desferol's causing a problem. Whereas for some people, as we know with XJ, for example, it may be the same with Jadnu. They
What
can't.
Stevie's trying to say is, why can't we just take Desferol orally, just like we do XJ?
Yeah. So unfortunately, Desferol can't be absorbed orally. So different drugs and different chemical properties, it means you can't actually take it orally. It won't be absorbed from the gut. So it doesn't work if you take it as a tablet or as a drink or anything like that. It doesn't work. So unfortunately, as a tablet, so it's about what works for the individual. Will it
I
work
suppose the
better?
question I was saying
Yeah.
is which one's better at
Yeah.
chelating from the heart and the liver?
There's no right answer
There's
to
no
that.
right.
So we actually think that it's desferone, Deferoprox. It's the smallest of the molecules, and so it's actually got the most proven track record with the heart iron. But we don't. When Jadnu, XJAD, and Desferone are very similar. Desferol are very similar. We think. In the end, it's different for every patient. So we've had some patients that have a lot of liver iron. We've actually got a group of patients that have a lot of liver iron. And for some of them, one's worked, and for others have worked. And in the end, for some, combinations worked. And it just seems to be very individual for different patients. There's no one right magic answer. And as much as anything, it's about what you can get in. Because we know that the biggest problem with iron chelation therapy is actually delivering it, is actually getting people to have enough of the treatment so that they can get enough of the dose of the drugs so that it works. And that's the really tricky thing. Sorry, I'm taking a lot of time.
Yeah, we'll make mine
Yes,
up.
definitely.
All right. So can we
I'll leave it right together. Yeah, I'll be real short.
one more? Okay.
Thank you very much.
Alright, so we're going to have supper now, but I'll also say that Julie Stolly has, do you want to hold them up, Tiana, has got some recipe books for sale for $15